Hi there everyone, my name's Justin Jew. I'm the Medical Director here at TFP Oxford, and a really warm welcome for you coming to join in to this information piece that's been put together by TFP about all things endometriosis. It's really timely because it's Endometriosis Awareness Month, and we felt as a group that it would be really useful to provide some information to fertility patients in the UK about what endometriosis is, how we can manage it when you're not trying to get pregnant per se, and then also how we might manage it through fertility treatments and how it might impact the fertility treatment we're able to do. So the first thing that I wanted to address is about what endometriosis actually is and how it might impact someone's fertility. In actual fact, endometriosis is quite a common gynecological condition. It's estimated that around 10 to 20% of women have some element of endometriosis. And endometriosis occurs due to endometrial-like tissue implanting outside of the cavity of the womb. Now, that endometrial-like tissue responds to the hormones that are controlling the menstrual cycle and periods, and so it can actually grow and also bleed when women are on their period. So classically, women might experience painful periods, they might experience painful sexual intercourse, or even pain when they're passing urine or opening their bowels, especially when they're on their period. So a really important aspect of endometriosis management is first of all getting to diagnosis. And there's been a lot of coverage about how sometimes it can take a very long time for endometriosis to in fact get diagnosed. So my first bit of advice really is that if you're worried that you might have very painful periods and you think you might well have endometriosis, I would encourage all patients to seek some help from their GP in the first instance. That way they can be clinically assessed with a history and perhaps an examination, and an ultrasound scan of the pelvis in the first instance might be really helpful to try and aid us find whether you have endometriosis or not. Now, when it comes down to whether endometriosis affects your fertility, I always think that a very important point to emphasise is that not all women with endometriosis will have problems with conceiving naturally. There are plenty of women who have endometriosis that go on to naturally conceive and go on to have babies and have families. However, we do know when endometriosis affects the pelvic organs, so the womb, the cervix, the tubes and the ovaries, sometimes that can make it quite difficult to get pregnant. So if we start from the bottom, really at the vagina, sometimes endometriosis can affect the back of the vagina and the back of the cervix. And that can manifest in really painful sexual intercourse, as I explained before. So couples can sometimes not really want to have sex because of the pain that's being caused. And obviously reducing the amount of sex that's happening in a couple's relationship will also reduce the chances of them becoming pregnant naturally. Moving a little bit further up in the pelvic organs to the womb itself, sometimes if there's endometrial-like tissue that actually leaches, if you like, into the muscular layer of the womb, that can also cause really painful, heavy periods. And again, that can cause problems with sexual intercourse as well. In addition though, if we've got inflammation in the womb in general, in the muscular layer especially, a condition that we call adenomyosis, that has been thought to increase the amount of inflammatory mediators and therefore reduce the chances of a pregnancy actually implanting. Moving further up still, so to the fallopian tubes, when endometriosis affects the fallopian tubes, it can cause blockage of those fallopian tubes, and for natural conception to happen, we rely on an egg released from the ovary to meet sperm after sexual intercourse. And usually that meeting and fertilisation of the egg happens in the fallopian tube. So if the fallopian tubes are blocked, we therefore can't get natural fertilisation of that egg for the embryo to develop and then implant into the womb cavity, and so therefore we can get tubal infertility, which may be associated with the endometriosis. Lastly, endometriosis can also affect the ovaries. It can cause cysts to form within the ovaries called endometriomas. Sometimes these are called chocolate cysts as well. Importantly, if endometriosis affects the ovaries, what can happen is that the volume of normal ovarian tissue is then reduced, and therefore the egg reserve that's left inside the ovaries will also be reduced as well. And the endometriosis affecting the ovaries in the same way if it affects the muscular layer in adenomyosis, if it's affecting the ovaries and causing an inflammatory environment within the ovaries, that will lead to a lower egg health, if you like, of the eggs that are being released from ovulation for natural conception. So if endometriosis is diagnosed, then that can be done by imaging, such as ultrasound scan of the pelvis or MRI imaging of the pelvis, or even keyhole operation to actually get a biopsy, so we get a tissue diagnosis of endometriosis, which is what we would always prefer. What I would suggest is that patients then want to know, well, if we've got endometriosis, how can it be managed? How can we control the symptoms and ensure it doesn't affect us, our future fertility plans moving on? And I suppose the management options for endometriosis can broadly be split into three different groups. The first group would be simple pain relief. So paracetamol and ibuprofen can be really, really effective in managing symptoms, especially if endometriosis is down at the more mild end of the spectrum. And obviously we can add other analgesics, things like weaker opioids like codeine, for example, and sometimes that's combined with paracetamol in cocodamol to try and help with pain. Next, we've got different hormonal treatments, and in fact, most hormonal contraceptives are very useful when it comes to treating pain, painful symptoms in endometriosis as well. So the combined oral contraceptive pill or any combined hormonal contraceptive, as well as progesterone-only contraceptives, can be used to try and help with menstrual symptoms. Things like hormonal coils, so intrauterine systems, are also very helpful in controlling pelvic pain symptoms that some patients have. And obviously, if we're controlling the pain symptoms, you'd also think that we might be able to reduce the progression of endometriosis, which unfortunately is a chronic condition, meaning that once you have it, you may well have it for a long period of time into the future. Lastly, we've got the option of surgery, and if you were opting for surgery, often you'll have seen a gynecologist, you'll have tried pain relief options and also hormonal options, and then the next phase would be to consider surgical options. So endometriosis, usually we would always prefer to try and remove it if we can, but sometimes some gynecologists may advise you just to have some endometriosis burnt, so using treatments, things like lasers or even diathermy, to try and ablate or kind of dampen down the endometriosis, usually through keyhole operations or even some robotic surgery now for endometriosis surgery. So many endometriosis clinics, sometimes doctors might be asked, well, how do the hormonal treatments actually help? So in part of that medical management of endometriosis, how does using things like the combined oral contraceptive pill or progesterone only contraceptive or even the intrauterine system coils like the Mirena coil, how do they actually help patients with endometriosis? Well, the key to it is what we're trying to do is to reduce the frequency that women are having periods. So if we have endometrial-like tissue growing elsewhere in the pelvis, causing inflammation and pain during periods and painful intercourse and pain on passing urine and opening bowels, then it would follow that if we can reduce the number of periods that women are experiencing during the course of a year, we will actually reduce the amount of pain symptoms that they're experiencing through the same duration. So using hormonal manipulation, we're able to stop the normal monthly menstrual cycle that's happening and therefore reduce the amount of bleeding from the endometrial-like tissue that's implanted in places around the pelvis where it should not be, where it's causing that inflammation and pain. A really common question I get asked in the fertility clinic from patients who have got endometriosis is, what can I really do to try and help my plans for having a family in the future? So I know that I've got endometriosis and I'm thinking about my future fertility. What kind of things should I be doing right now? So the first and foremost are the basics. So lifestyle factors are important for every single patient, whether they're in a gynecology clinic, an endometriosis clinic, or a fertility clinic. So I'd really encourage patients to have a really good whole food diet, try and steer away from ultra processed foods, ensure they're doing nice regular exercise, and they're maintaining a healthy body mass index. The next thing is, again, just to get to that diagnosis really early and then have contact with your local endometriosis clinic. Getting your symptoms under control is a really important facet to try and help your fertility in the future. The more that we can control your pain symptoms, the less likely your endometriosis can progress. Clearly, sometimes endometriosis may well progress despite those measures, but I would prompt any patient who's thinking about their future fertility to A, be diagnosed with endometriosis if it's there as soon as possible, but also engage with their local endometriosis clinic so that we can get good disease management so that it doesn't impact your tubes or your ovaries or your uterus for the future. Another really common question or scenario, if you like, that we have to deal with in the fertility clinic is actually for when endometriosis patients are presenting for fertility treatment and considering to have endometriosis surgery. We're really lucky at TFP. We work alongside some amazing endometriosis surgeons and reproductive surgeons just the same through the NHS and also in the private sector. So what's really important, I think, when we're considering surgery to aid your chances of getting pregnant is to really think together as a group. And you'll hear this term, this MDT approach, all the time. And what that stands for is a multidisciplinary team approach. So in order for that to happen, we need really good radiologists to ensure that we've got brilliant imaging from ultrasound scans and also MRI scans of your pelvis. You need a good IVF consultant as well that's thinking about perhaps what might happen if we do surgery to your prospects of having IVF. Might it improve the outcomes that are achievable from IVF, or might it actually have a detrimental impact as well? And lastly, of course, we need a really good endometriosis surgeon who's also going to think along the same lines. So there's a real delicate balance between fertility and endometriosis surgery, especially when we're operating on the ovaries. On one hand, we want the endometriosis to be gone from the ovaries so that the ovaries are not inflamed, and so therefore the egg health that is possible from egg retrieval in an IVF cycle is better. But if we remove too much endometriosis from the ovaries or remove endometriomas, so that cysts associated with endometriosis, that might also reduce the total amount of ovarian tissue that might respond to stimulating IVF medications. So this is exactly why we need a really good group approach. And what I would say is that TFP, that's exactly what we consider. If we're worried about potentially doing IVF treatment and say being able to access normal ovarian tissue and the follicles to be able to retrieve the eggs because endometriosis is making that very difficult, not just because there's endometriomas in the ovaries, but if there's distorted anatomy from scarring from endometriosis, we may well ask for one of our colleagues who's an endometriosis surgeon to also see you in clinic and talk to you and counsel you really well about the benefits and the risks of having an operation. At the same time, we'll also be thinking, well, if we do that surgery, will it benefit each individual patient or cause potential harm in reducing egg reserve? So the answer is not a straightforward one. Not all endometriosis patients need surgery before they undergo IVF treatment. Often the right answer is actually to go ahead with IVF treatment first and then opt to have endometriosis surgery later. But as I said, it's not a one size fits all solution. So what's really important is for you to come into clinic, have a really good clinical assessment and consultation so that we can take that MDT approach and advise accordingly and tailor that management plan according to the type of and severity of endometriosis that you have. So hopefully we've covered a lot of elements around endometriosis and fertility. If you are worried that you may well have endometriosis, then I think your first port of call should be to go and see your GP. They'll be able to do that really good, thorough clinical assessment and advise accordingly. If though you know that you already have endometriosis and you're worried about fertility, then my advice would always be to seek out a fertility specialist. You can reach out to your local TFP clinic, and we should be able to provide you some really good advice about how to manage your endometriosis and when fertility treatment might be appropriate. So thanks again for watching this information piece.